I have been, I'm going to be taking kind of a turn from the more research-oriented talks that you've been hearing, but I'm going to go through, as was just noted, where we are right now. And this is more of a kind of a reality check in terms of the status of COVID-19. So we've been through a very, very difficult 8 months now, and this is an evolving dynamic situation, and every time I give this talk I try to get it as updated as possible so we know exactly where we are today and yesterday versus even a week ago. So here's what we know, and here's what we don't know really about the pandemic. And first of all, in terms of what we know, there is a list of things that we know, and we know that that the SARS-CoV-2 was a novel, lethal infection. It's ubiquitous. It started in China, and we know that the cases have been rising and falling, and the fatalities have been also rising and falling. But the overarching reality, and which I'm going to show you in a second, is that we're in the middle still of a very severe and unyielding pandemic that has, in many places in the US and around the world, we're seeing big upticks in cases and fatalities, even in places where it had seemed to have been under control for some period of time. You know, the geographic waves of prevalence and incidence are evident, and we see this including in the United States, where we've had the really hot zones everywhere from the Northeast to the Sun Belt and now in the Midwest. But I don't think any of the places that had really serious problems are anyway out of the woods, and we're starting to see some, as I'm going to mention in a minute, some upticks even in New York. I personally do not see the end of this pandemic at the minimum before 2022, 2024. It's assuming we have a good, effective, and safe vaccine that people actually will agree to take. But even if they do, I still think this is a situation that may become actually endemic. We really don't know a lot, maybe a lot more than we do know about this virus, and I think some of the research talks that you just listened to underscore that reality. But we're not exactly sure about the real infectivity rates. Whether it's any infected individual can affect 2 or 3 other people or 5 or 6 other people remains to be seen. In terms of the medications that we have, these are still a work in progress. We have a number of experimental or compassionate use drugs that have been used, and I'm sure you've heard plenty about this in the news, but remdesivir, dexamethasone, monoclonal antibodies, et cetera, are all drugs that we use in a hospital setting, and I'm going to get back to that in a bit. But none of these are fully established in terms of a clinical research base that says unequivocally that they're to be used, they are to be used, they work, and what circumstances. The vaccine issue, obviously one of the hottest issues of all here. I'm going to go into that more specifically later. I'm assuming we'll get a vaccine that works and that is safe, but right now it's an assumption. It's not proven fact. We don't really know why some countries are hit harder than others, or regions, and this is also a work in progress. There are ideas, but no, again, definitive science that can help us there. We don't even know whether COVID-19, if somebody has it, are you conferred immunity? Probably yes, but for how long, who knows? And also even the clinical medical impact of COVID is something that remains incomplete in terms of our knowledge base. I mean, it's clearly not just a pulmonary situation, it's a vascular disease. It has caused strokes. It has caused serious GI problems. The SARS-CoV-2 can live in the GI tract, it often does. And the long-term implications, there are some people who have now lost sense of taste and smell for 4, 5, 6 months. Will they get it back? Who knows? There have been cognitive difficulties, psychoneural problems that that may or may not be long lasting. But I will tell you that there are people setting up long-term follow-up clinics all over the country for those who have had COVID, but who need to be followed for a variety of systemic issues. So where are we? So as of yesterday, and beware winter is coming, as you see up here, is true. And I meant this in sort of the Game of Thrones sense, but also the reality is that almost everybody that deals with this feels that we're going to have very serious impact this winter with COVID. We don't know what actually the interaction is going to be between COVID-19 and seasonal flu, but we'll soon find out. So globally, as of yesterday, over 35 million confirmed cases. And why say, is that equivalent to 350 million? Because the number of confirmed cases in the US and internationally, of course, and maybe more so internationally, the confirmed cases are only a fraction of the actual cases. And many people, including Dr. Fauci, have said, and Dr. Redfield at the CDC, have said, let's assume that the confirmed cases are 10% of the total number of people actually infected. That would mean there's 350 million people minimum infected internationally and more than 1 million fatalities. Surging, I'll show you a map, but basically different places in Europe, South America, Africa, and so on. In the US, we now have, as of yesterday, 7.5 million confirmed cases, meaning that probably 75 million Americans have had COVID. I think we're getting even closer to 210,000 fatalities. And by the way, a note about these fatalities, virtually everyone believes they're undercounts. These are undercounts, and why they're undercounts is there's a number of different reasons why we might think about that. If you look at overall fatalities in this period of time, let's say from February to now, versus the same period last year and the year before, we have overall total fatalities in the United States at a pretty much higher level than they had been, and this probably represents some undercounting. And also the criteria for counting, there were some medical examiners' offices who only counted those people who had confirmed cases versus people who might have not confirmed by test, but pretty sure clinically that they had COVID as a cause of death. Surging in the US, we're going to look at a map about that also, but along the Midwest in places like Montana and Missouri and so on are seeing significant upticks. We're looking now at the beginning of a trajectory which looks upward bound in New York and in New York City. This has profound implications for the schools, obviously. Are we going to keep them open? Are they going to close? What are we going to do? We're already closing schools in 9 zip codes in New York City where there's been outbreaks, mostly provoked by mini outbreaks in the Hasidic Orthodox Jewish community in the yeshiva schools and so on. So, but there have been already issued by the state and individual healthcare networks in New York to get ready for surge. In other words, think about voluntary admissions, elective admissions, and so on. So we have some serious evidence or suggestions that we might be starting to see right now important resurges in New York area. So that means that hospitals and health systems need to start thinking about a variety of issues, not only the capacity of the hospitals, but also staffing, also PPE, and other issues they're going to have to deal with. For example, if there's a serious outbreak, will access to remdesivir and other experimental drugs that I mentioned before be assured. And I'll tell you that there is concern among some hospitals that we won't have enough PPE, specifically things like N95 protection masks. So we shall see. So this is just what I was referring to earlier, that the predominant caseloads of COVID. This is a couple weeks old, this slide, but it's really more or less the same here. Texas, Florida, California is actually more under control than you see there, and of course in the Midwest. By the way, I just want to note as a side note here that a lot of places that are seeing surges, continuous surges in COVID are also places where there are overlapping disasters. The Gulf Coast, for example, is being hit very, very hard with hurricanes. It's been a terrible, devastating hurricane season. And of course, the wildfires on the West Coast in California, state of Washington and Oregon. And I'm mentioning this because there's a lot of concern that the steps one would take to help people who are experiencing wildfire or a hurricane where they have to be evacuated rapidly. They go into shelters where conditions are not always conducive to controlling the spread of COVID. So we have actually conflicting challenges that have to do with what do we do with populations that have to evacuate rapidly, confronting a wildfire or a hurricane. In some places, this is working better than in other places, but this is really pretty serious problem. And this is just a graphic map demonstration of where we're seeing outbreaks, and this is in flux. And one of the things that's pretty concerning is the increasing uptick in parts of Europe. The UK is a mess, and we're seeing outbreaks in the Middle East still and all that, but as well, and then, but also in Europe, and France and Spain, Germany, which has been doing a great job up until now, is seeing more cases just over this last week or two. And the real global hotspots remain in the United States, in Brazil, and India, all of which show no signs yet of really softening. So we have lots and lots of cases in those countries. A little more information about in the US. As I said earlier, the Sun Belt, the South, and the Midwest. We're seeing more people contracting the illness and more deaths among younger people, although the fatality rates are lower in younger people. They're not anything, close to zero. There's plenty of people who are getting very, very ill who are younger. And sometimes it's from the secondary consequences, not pulmonary, but issues with cardiovascular, specifically cardiac consequences that are affecting younger people. So we're seeing more people infected, and the demographics changing, and lots of implications of that, including athletes who seem to be particularly prone to getting some cardiac consequences. Along with this are increasing hospitalizations. The denominator is increasing, as I was saying before, so there's lots of people with asymptomatic COVID, but we're still seeing, from a quantitative point of view, increase in hospitalizations in many places, which is why places like New York, which was the global hotspot in April and May, and then really, really calmed down here. And New York ended up being one of the least impacted from COVID of any state and region in the US, which was good, but now, as I said, there are increasing concerns about that. The other thing that's been a problem here in getting things under control is extraordinary inconsistencies in federal and state policies, to the point where we have random acts of response and preparedness. Businesses open different ways in different places, schools open in different ways in different places. All of these policies are being left up to governors and local jurisdictions like mayors, because federal policies and recommendations and messaging from the White House has been so insane that it's really hard for individual state to get much out of what is being recommended, not just by the CDC, but sometimes the CDC's message is inconsistent with what the president or vice president are saying. And that's just left us open to these randomness of the impact, which is pretty dangerous. The other thing about the messaging, I just want to mention this. When we start to reopen, you know, the first state to quote unquote reopen business was Georgia on April 24th. The problem is that when many people hear the word reopening, whether it's businesses, restaurants, bars, gyms, whatever it might be, the word is reopening, but they're hearing something on the order of we're getting back to normal. And once that message is out there, we have people getting increasingly lax about things like distancing, wearing face masks, and so on. And when the president of the United States, that's POTUS, is reinforcing resistance or hostility to the basic public health messaging by his words and by his optics, that's a problem. We're going to be talking about the recent realities as it pertains to the president of the White House in a bit. Just a note here, because for a long time, the White House and the White House Task Force has been claiming that the increase rates or the prevalence of COVID was due to more testing. It's just preposterous, but I just wanted to mention it as we roll along here. I think this notion of what causes a region or a city to start exploding again in cases, and there's a lot of scenarios, but let me just say that the reopenings, first of all, are the main thing. So when colleges and universities reopen and people are coming back to work and back to school, that is a natural and understandable possibility for how these reinfections are getting started. Kids are going to come home for the holidays shortly, but in terms of numbers, over 130,000 cases have been identified among positive cases via testing, have been identified amongst university and college students, including 90 deaths. So all these young people, let's say they're at school right now, Christmas, Thanksgiving, and all the other holidays that are going to come up this season. If students are going back home to their families and their communities, we can see the potential for why, one of the reasons why this winter is going to be rough. And then I think this is something that's concerned me for quite a long time. So we're now, I think we have probably opened one way or another schools across the country now. That's so in pre-K to 12th grade, there are 55 to 56 million students involved. Protocols are not standardized. There's no science behind a lot of these protocols. The schools are not ready for, in many cases, for full-time education, which is why only New York has any, among all the large city school systems, only New York has so-called hybrid system situation where some large number of children are learning remotely, but some kids in New York are, of course, those of you who have children in the New York school system know that some of the schools are open. Most of them, I guess, in the public school system are open for in a hybrid way. In other words, your kids may be going a day or a few days a week, but much of the learning is taking place remotely. So this remote learning, by the way, I should also point out, this is a nightmare for low-income children from low-income families, where access to the internet or hardware or mentors is absent. So that children, there's like 1.1 million kids in the New York City public school system. 700,000 are at or near the federal poverty guideline. And many of those students who are not doing well before COVID now have had their education interrupted. And many of them don't have the facilities or the backup to do remote learning. So kids who were behind the 8 ball in January are in a much worse situation today. And it's just a tragedy. The tools we need to proceed, first of all, the hospital drugs. That is the remdesivir, dexamethasone, monoclonal, polyclonal antibodies. We really need those, and those are well on their way to being standardized and approved. Point of care testing, meaning that place like a pregnancy test or blood sugar, you don't have to send samples to the lab. We should be doing a minimum of 20 million tests a week, which we're not even close to, maybe more than that. And we don't have that yet. By the way, what you're seeing here is in order of when I think we're going to actually have whatever it is that's on this list. In other words, the first thing we're going to see, in my opinion, will be the approval of these hospital-based drugs. The second thing is we're on the verge of seeing many more point of care tests available, but the FDA is taking its sweet time in giving the emergency use approval or full approval to any of these. We need consistent evidence-based national policies that under no circumstance is going to happen in the near future. If Biden gets elected, maybe after he's inaugurated, we'll see something of this kind of policy development, but I would not get your hopes up anytime before that. We also need ambulatory drugs. If you get seasonal flu and you catch it early, you may get a prescription for Tamiflu, which may shorten the disease course of influenza and reduce the severity. We need something like that for SARS-CoV-2. We don't have that yet, but that would be a huge game changer. We need vaccines, obviously, and I'm going to talk about those in a minute. So this is the order which I think we'll be getting what we need. And the point of care testing, ambulatory drugs, and vaccines would be the true game changers. Testing, I'm not going to go into this detail, but this is from the FDA. There are different kinds of testing for SARS-CoV-2. There's pros and cons to all of them, including how long it takes to get the results back and so on. But you know, an antibody test or serology is something that we're doing, and there's lots of issues with this. We could take this up in Q&A if you want to. There are companies developing things like this. This is a pod that you could put at a convention center, at a school, at a university, whatever, where you have
2 minutes, Irwin.
Pardon?
2 minutes.
2 minutes. Okay, let me roll along here. Vaccines. Let's deal with that in questions in Q&A. I do want to end with the issue of the political conditions that affect everything that we're talking about here, and no living person is unaware of the fact that the president tested positive last week. All kinds of problems with unclear or non-transparent or frankly dishonest messaging from his doctors, and the insanity of having the president be sent from Walter Reed back to the residence. Those of you who watched the video of him getting off the helicopter and walking up the stairs, getting to the balcony, I'm sure noticed him gasping for breath. He looked like crap, and he's infected. This man is a walking super spreader and conducting events over the last many, many weeks, all of which are super spreader events. It's a disaster. So I'm going to leave it at that. This is the president's tweet from a couple days ago. Don't be afraid of COVID. Don't let it dominate your life, et cetera, et cetera, et cetera. But anyway, I think we'll stop there. And if there's questions, I'm happy to take them.
Thank you, Irwin. Very thought-provoking. We have a question from Rodney Rothstein. Rodney, please go ahead.
Irwin, thanks. Thanks for a great presentation. I had two questions. One is, when you, not just you, but when the CDC shows the number of cases, they show it as number of cases, but they don't show it as a per population, wouldn't it be better to show it per population? Because, you know, states like Maine and New Hampshire and Vermont show low cases, but they also have small populations. That's one question. And the second is, you had it in your slide, but you didn't mention it. Why are fatality rates dropping?
I think they're dropping, just to take that question first, they're dropping as a percentage of the total population, because, you know, very early on, many of us were predicting that half the US population was going to get infected at least, and the majority of which would be very, very mild symptoms or even asymptomatic. That means that 160 million Americans are going to be likely getting the virus. As we're seeing more, the denominator is increasing. The fatality rates are, you know, as a percentage of cases, it's just dropping. But even if we suggested that something like in the vicinity of 0.5% of the cases ending up either very sick or dying, we're still talking about 800,000 to 1 million bad outcomes from this disease. So I think that's really the issue. But the other question about the CDC, they could do both. Rodney, they could be both. You're talking about looking at percentage of or a population-based rate of the positivity and the actual raw numbers, and both of them would be appropriate. Data collection and dissemination has been a major controversy with many people, or many organizations and agencies in the federal government. You know, it's gone, that data collection and dissemination has been always a job of the CDC. It got taken away from CDC, put into somewhere else in Health and Human Services, and it may be going back there to the CDC. So it's just a mess. And many states, there are states that decide they're not going to share data for whatever their own reason is. So it's I don't know what to say about it. It's just unfortunate, bad leadership.
Thanks, Irwin.
Neville Kleins, you can talk.
Yeah, hi, thank you. You put vaccines on the bottom of your list, stressing that you thought this was going to come last. I presume this is a commentary on uptake and distribution, but if you could just comment on that.
Yeah. So this is something, I have actually spoken to Fauci a number of times about this directly, because he's a proponent of the notion that we will have vaccines available by the end of the year, November, December. That is true. They'll probably be available. My question to him, which I've never gotten a satisfying answer about, is what do you mean ready? Are they, you know, normally it takes years to establish real safety. You know, efficacy we can get relatively soon, and that's the case with many of these vaccines in the pipeline. Safety, you know, the fastest vaccine we ever developed was mumps. That took 4 years. It's very common for vaccines to be observed for 10 years or more before they're sort of let loose into the population. So I think what's going to happen is we will have vaccines ready, and they'll start being administered to people, you know, frontline health workers and central workers, et cetera. But it won't be in the general population available until mid or end of 2021. And we're optimistic about it, but the fact is that we have a huge anti-vax movement in the United States. And I am not confident that the uptake is going to be very easy. And some of these vaccines require incredibly sophisticated cold chain transportation, because they need to be stored at, you know, minus 100, 110 degrees Fahrenheit. And some of them are 2 doses, 3 to 4 weeks apart, which makes it all very, very complicated, unfortunately. So I think optimistically, second, third, fourth quarter of 2021 before it's available to the general public.
Irwin, if I could ask a question. It's really easy to understand how there's an undercount in terms of the actual COVID-19 cases. What I was wanting to ask you to follow up on is the number with respect to the fatalities. What factors might contribute to that being an underestimate?
Well, first of all, for a long time, let's just take New York City. So who was tracking fatalities? One was the medical examiner's office, and two was the Department of Health. The Department of Health was saying that, actually I may be confused about what you're saying, but one of those entities was saying, we are counting only those fatalities where there was a definitive positive test for SARS-CoV-2. The other entity was saying, no, we're counting the clinical cases, what I think was the ME's office, the clinically established cases, in addition to the testing proven cases. So that was just one in a kind of one spot where there was inconsistencies about what we measure. And the second thing is that in many places in the country where testing is very minimal, they don't actually know who actually died of COVID. And then there were secondary deaths. So if you didn't have COVID, but you were sick with, let's say, chest pain in April in New York City, your care might have been very delayed, and you will die of a coronary, of a heart attack. Not COVID, but that death was certainly related to the fact that the medical system was overwhelmed in terms of hospital care. So delays in bringing patients to hospitals, people dying at home, et cetera. Lots of factors might have contributed to the fact that we really truly undercounted fatalities. Eric.
Okay, and there's a question posted in the Q&A, and I'll read it. One of the projections is for 400,000 fatalities in 2020, which is comparable to the number of deaths from influenza in 1918. 1919 was much more deadly. Should we psychologically prepare for an analogous increase?
Yeah. So actually in 1918, there were, as far as people know, about, I think the number is 675,000 deaths from the Spanish flu. And our population was a fraction of what it is now. So that was a huge lethal event in 1918. I think 400,000 by the end of the year is optimistic. I think by the end of 2021, we'll probably be in the 600,000 to 800,000 range, if not more. It depends on how rapidly we'll have an effective and safe vaccine out there. But I think we ought to gird ourselves for an unending, relentless challenge trying to deal with the consequences of a situation that should have been but wasn't under control. By the way, Eric, I could just like to say that if you look at our fatalities on a population basis compared to Germany or certainly South Korea, it is somewhat unconscionable that we weren't able to take the steps that some of these other countries took to get much better outcomes, unfortunately.